my name is Stephanie Merlino Barr. I'm a registered dietitian nutritionist in the neonatal intensive care unit at Metro Health Medical Center, a level 3 NICU in Cleveland, Ohio. I'm also an adjunct instructor in the Department of Nutrition at the Case Western Reserve University School of Medicine, where I teach about human lactation. Today's course on targeted fortification is just one in a series of subjects brought to you by Channel 1, On-Demand Nutrition Education. Today we are looking at targeted fortification and presenting a case study to highlight the implementation of this approach to preterm infant nutrition. My objectives for today are, first, to review the necessity of fortification in very low birth weight infants. Next, to identify the variability of macronutrient concentration of human milk. Then, to define what targeted fortification is and how it differs from other methods of fortification. And finally, I will illustrate how targeted fortification is implemented in the clinical NICU setting in our case study. Parents' own milk is the ideal source of nutrition for most infants, and this is especially true for very low birth weight infants, which are defined as those born less than 1,500 grams or less than 3.3 pounds. Human milk is the ideal feed for these high-risk infants due to its unique nutritional and non-nutritive factors, including immunoglobulins, oligosaccharides, which contribute to the development of the infant's immune system and gut microbiome, improved feeding tolerance compared with infant formula, due in part to the enzymes within human milk that aid in digestion and absorption, and finally, the association with decreased incidence of complications of prematurity, including late-onset sepsis, necrotizing enterocolitis, bronchopulmonary dysplasia, and retinopathy of prematurity. For these reasons, the AAP states that human milk is the preferred feeding for nearly all newborns, but they clarify that human milk fortification is required to meet the nutritional needs of preterm, very low birth weight infants. Why is human milk fortification necessary? Here, the estimated nutrient requirements of very low birth weight infants are listed, along with the estimated nutrition provision of human milk at a volume that meets the estimated energy requirement of 120 kcal per kilo per day. You can see that the estimated values of unfortified milk fail to meet the protein and micronutrient requirements of very low birth weight infants, despite the energy requirement being met. Thus, fortification is required. The column on the right displays fully fortified human milk, or 1 packet of human milk fortifier to 25 mL of expressed human milk. Here, it meets all estimated nutrient requirements for the very low birth weight infant. While estimated values of human milk are published and used for reporting nutritional intakes and research reports in daily rounding, these values are truly estimates. As displayed here, Growargo et al. In 2014 measured the variation within and between breast milk from mothers who birthed infants born less than 2 kilograms and were admitted to the NICU. These analyses used 24-hour representative samples and were assessed via mid-infrared spectroscopy. Their findings, depicted here, show that the variation was greater between mothers and was especially evident in the protein variation, displayed as BAP, or bioavailable protein. Macronutrient composition of human milk is well documented and can vary based on stage of lactation, length of gestation, period within a feeding, for example, foremilk compared to hindmilk, parental factors, method of expression and storage, and method of administration. These variations are not critical to account for in the feeding of a healthy term infant. However, for the preterm, very low birth weight infant, these variations are incredibly important to recognize. So, what happens if human milk's actual composition does not meet its estimated composition? Even with fortification, administered nutrition may not meet our estimated requirements, leading to a cumulative nutrient deficit throughout the NICU stay. This graph displays 3 scenarios using 3 different published values of protein content in human milk: 1.4 grams of protein per deciliter, 0.9 grams of protein per deciliter, and 1.62 grams of protein per deciliter. If we assume that our very low birth weight infant's estimated protein requirement is 4.5 grams per kilogram per day and use standard fortification, we will not meet our estimated daily protein requirement for 2 out of these 3 scenarios. This graph depicts the cumulative deficit over a 14-day period. The human milk with an actual protein content of 1.62 grams of protein per deciliter has no deficit. The milk with 1.4 grams of protein per deciliter has a minor protein deficit, and the human milk with 0.9 grams of protein per deciliter has a substantial cumulative protein deficit after 14 days. Why is this deficit important to recognize and correct for in a preterm infant? because cumulative nutritional deficits lead to slowed growth and may contribute to poor clinical outcomes in this high-risk population. We are able to account for macronutrient variability and improve the enteral nutrition administration to preterm infants using targeted fortification. To provide some important definitions, standard fortification is the practice of fortifying a specific volume of human milk with a fixed concentration of commercial human milk fortifier per manufacturer instructions. Individualized fortification describes the practice of a patient-specific fortification plan, typically using targeted or adjustable fortification, in which macronutrients are modified on top of standard fortification practices to meet nutrition goals. Targeted fortification uses human milk analysis to identify actual human milk macronutrient composition and provide fortification to ensure a fixed target of energy and macronutrients are provided. Adjustable fortification uses the patient's blood urea nitrogen values to titrate protein fortification, with more protein being added via protein modulars when BUN levels fall below 10. I will briefly review the advantages and disadvantages of each of the listed methods of fortification before diving into targeted fortification and our case study. First, standard fortification. It benefits from being a practical and readily available method of human milk fortification that has distinctly improved nutrition administered to preterm infants. However, this method of fortification does not take macronutrient variability into account and may result in poor growth. Next, targeted fortification. This method benefits from allowing adjustment of energy and all macronutrients in individual patients. However, this method requires the utilization of a human milk analyzer and is labor-intensive. Additionally, it relies on population estimated nutrient requirements rather than an individual patient's needs. Finally, adjustable fortification. This approach is practical and minimally labor-intensive compared to targeted fortification and improves protein administration based on an individual's requirement. However, adjustable fortification requires frequent blood draws and does not account for variation in energy, fat, or carbohydrate requirements. Now, moving on to our case study in which we use targeted fortification to improve the nutrition plan for one of our NICU patients. Recently, a mid-infrared human milk analyzer, shown here, was approved by the FDA for clinical use in the United States. The FDA approval has increased interest in the targeted fortification approach. In a recent national survey of NICU dietitians that we conducted, 12% of respondents indicated owning some type of human milk analysis equipment, and 7% of respondents mentioned specific plans to purchase a Mirror's human milk analyzer. The analyzer can manage macronutrient concentration on a small sample of human milk, and the results are used to construct a unique fortification plan for that baby rather than assuming the macronutrient concentration of human milk and using a standard fortification plan. Human milk analysis and modification of the fortification plan is recommended to be performed 1 to 2 times per week. To illustrate the successful utilization of targeted fortification using human milk analysis, we'll look at baby L, who was born at 25 weeks gestation and 810 grams, or 1 pound, 12 and a half ounces. Her medical course was relatively typical for a preterm infant. Most significantly, she developed bronchopulmonary dysplasia and was discharged from the NICU on a nasal cannula. Baby L's weight gain, as documented on the 2013 Fenton growth chart, is displayed here. Per our unit guideline, human milk analysis started at approximately 2 weeks of life. This was done so that all colostrum was preserved for the infant and mom's milk production was determined to be sufficient to support human milk analysis. We collected a 24-hour representative sample by pooling all of mom's milk into a single container and taking a 10 to 20 ml sample once a week for analysis. This volume was selected to allow for multiple analyses to confirm milk values. From this weekly analysis, we mapped out our nutrition plan to meet our goal energy and protein intakes. Let's walk through baby L's major nutrition milestones displayed here. Enteral feeds of express breast milk were initiated on day of life 19, slightly delayed due to early life critical illness. Between 30 and 32 weeks post-menstrual age, the following was accomplished. Fortification was initiated using a hydrolyzed protein liquid human milk fortifier. Parenteral nutrition was discontinued, and full fortification was then reached. At approximately 33 weeks postmenstrual age, targeted fortification was initiated utilizing liquid protein to meet a protein goal of 4 to 4.5 grams per kilogram per day. Baby L was ultimately discharged from the NICU at 39 weeks on a combination of express breast milk and preterm infant formula due to a diminished breast milk supply. Throughout her NICU course, her weight gain was consistent and appropriate as shown here. As it is critical to look at more than just weight when assessing growth, Baby L's length is displayed here. On all accounts, this patient had consistent and symmetrical growth throughout her NICU course and after NICU discharge. We have visualized Baby L's successful growth during her NICU stay. Now let's dive into the details of our nutrition plan, which utilized targeted fortification. Here, the estimated nutrient requirements of a very low birth weight infant are again listed, along with the estimated human milk composition, Baby L's actual human milk composition, Baby L's actual human milk composition following standard fortification, and Baby L's actual human milk composition following individualized fortification. All of these values are presented in volumes that meet the estimated energy requirement of 120 kcal per kilo per day. Let's take a closer look at the variation between the estimated and actual values of Baby L's milk. While the energy density is similar, protein does differ significantly, with Baby L's milk from this specific sample containing 0.6 grams per kilogram less than expected. Using targeted fortification, we were able to knowingly meet our daily protein intake goal of 4.3 grams per kilogram per day. Had we used standard fortification practices, we would have only provided 3.8 grams per kilogram of protein daily. So what difference does half a gram per kilogram per day make? In a day, probably not too much, but cumulatively over an entire NICU stay, as we have seen, it absolutely adds up. Utilization of targeted fortification for Baby L allowed us to maximize her enteral nutrition administration, promoting optimal growth throughout her NICU course. To conclude, human milk requires fortification for very low birth weight infants. Human milk energy and macronutrient variability is important to consider in creating nutrition plans for very low birth weight infants. Targeted fortification is just one method to improve enteral nutrition administration and can be successfully implemented into the clinical NICU setting. I would encourage you to watch for upcoming Channel 1 videos on nutrition and learn more from my esteemed colleagues. Have a great day. Thank you.